Good afternoon, everyone, and thanks for the kind invitation. I have my clock here because when we sometimes stand behind the pulpit, we, go over time. So as I've been introduced, Charles Kwaku is my name. My day job, or what takes quite a lot of my time, is the work I do with the Caribbean African Health Network. I have other hats on, working across the city region and at national level as well. So I'll be telling you a bit about what we do and some of what we found as well. Great. So CAHN, came about 5 years ago. It was on the back of our chair, Dr. Faye Bruce's PhD, that was looking at cardiovascular disease and why Caribbean African people tend to have poorer outcomes. And some of these data have been there for a long, long time. So more recently, what we say is COVID hasn't taught us anything new. Yes, it's shown a light on some of the key issues, but it's given us a real opportunity to be involved in some of the discussions and conversations. And so for us, the vision is to eradicate health inequalities and wider disparities for Caribbean African people within a generation. And back in 2017, that was just about the start of devolution for Greater Manchester. We know from Friday, it's the ICSs. So then the more she ran her focus groups, people were asking what she was going to do with the data because they get consulted and don't hear anything back. And so, 10 people came together and set up the CAHN. And for us, really, that mission is ensuring that we feed in at a strategic level, because there are lots of Black-led organizations that will be doing various pieces of work, running for, peer support groups and frontline grassroots stuff. But where the gap is when it comes to policy and influencing that. I won't go through this, and you can't read the text font size. But for us, really, objectives is all about collaboration. So whilst we health and well-being, we're also very conscious of the wider social determinants of health. And as many of you know, Michael Marmot and his work on, health inequalities and the Marmot City region. So yes, it's looking at cross sectors, looking at how we work with other, voluntary sector organizations and support them and try and explore partnership, but also other sectors, how we able to take that lived experience into those spaces, and then also championing the assets within our community. So one of the unique selling points, and it's great to see you this year, because she's been there right from the start, is making sure we championing the assets within our community. And one of our USPs is access to Black clinicians up and down the country. And since the start of the pandemic, from the 2nd of May, every Saturday morning, we'll have a Caribbean or African clinician who will present to the community on Zoom, live stream to YouTube and Facebook, and then take questions as a way of helping ourselves to do for self what we can, because we can't depend on the public purse for everything. So for us, championing those assets are really important. And why we were set up and what's the problem we're trying to address, it's about that poor access. So quite recently, with Core 20+5 and the other national initiatives that talk of equitable access, that's so important. But whether it's language, whether it's, historic issues that prevent people from presenting early, those are some of the things we're seeking to tackle. And then the lack of trust, which we found during our work with the vaccines, was the biggest barrier. People could not trust the fact, and we say all the time, various meetings with senior government ministers and even the Prime Minister, they couldn't just get their head around why we have vaccine is free and people, from Black and Asian minority ethnic communities didn't want to have that. But we knew about the hesitancy and the lack of trust way before that. Also poor engagement, and the last clinicians that presented talking about hard to reach. There's no hard to reach community. It's usually the model of engagement that doesn't work, and it needs to be flipped on its head. So for us and some of the work we've done, so long as we get the messaging and we come up with a model, and we have a model that has worked. So right from, HIV, testing in churches on Sunday, recruiting organ donors in church on Sunday, we've done it. It's health screening on Sunday in church. We've done that, and, referring people on. So it's the model of engagement that doesn't work. But usually, our other sectors don't want to invest in community engagement and research as well. And then inadequate knowledge of some of those issues that particular impact on ethnic minorities. So, early this year in the UK, for the first time, a drug was approved for people living with sickle cell. In mainland Europe, they've had medication for years, but for the first time in the UK, the medication was approved on the NHS, and whole issue around commissioning and all that, we can go into it. For some of us, it's about making sure we chip in our way and flagging up some of those key issues, about those particular conditions. Every day in the NHS, a black woman will undergo fibroid surgery. But we're not investing a lot into prevention. And that is why for some people within our community, discovering a vaccine for COVID, whereas HIV for 20, 30 years, there wasn't medication and people couldn't afford overseas. They didn't want to trust that this was meant for them. And then also the bias in the system. So whether it's institutional, racism, structural, it is with us, and for us, when we talk about that, it's not pointing fingers at individuals, but it's more about looking at the structures and the systems that tend to exclude people. So for us, the health streams, we tend to focus on cardiovascular, which started the organization, the cancers. So we all know 1 in 4 black men will have prostate cancer, but the age for testing, it's just around 50, but we know for some of those things, it impacts and affects our community a lot earlier. So we keep chipping away, working with, clinicians and trust and institutions. Mental and emotional health. So once again, another area where there's disparity, whether it's about sectioning young black men and, people not responding well to treatment, but the respiratory stuff as well, including COVID. Then blood-related stuff, we've been doing that, sickle cell, lupus, and others. And then reproductive and sexual health. Only recently, maternity has been taken really seriously. And the fact that, until 2019, black women 5 times more likely during childbirth to die, and now it's received that attention. So I'll whiz through this. So for us as an organization, in order to tackle this, we're looking at community engagement and empowerment. So not just engaging with our community, not just bringing along researchers to run focus group and get information and intelligence, but making sure the community is empowered as well. We have a range of health and well-being services we run. So in response to the pandemic, we started a Black-led mental health service, providing counseling, bereavement, peer support, and other low-level mental health stuff. And we've seen to over 400 people, providing 8 to 12 sessions, and sometimes when it's complex, more than that. And we know, with the Greater Manchester Bereavement Hub that was set up in 2020, it wasn't black people weren't assessing that, but they were coming to our service, and we've seen, over 100 odd people. But then also training, it's really important, and leadership development and all that. So we're really delighted the Health and Social Care Partnership has commissioned us to run a Black Health Improvement Program, and it's for primary care and its workforce, and there's an accreditation aspect to that. But really helping clinicians to understand what really matters to our community and how they can get the best outcomes. So proud to be in commission when some of the clinicians, we're really struggling to get our black patients to keep their blood pressure down. And we're saying, do you ask them whether they're having any herbal remedies? Do you ask them whether, yes, they come and see you for their regular checks, but they're not having the medication because some of them feel things are too westernized. And so some of those conversations, but also the role that faith plays, when it comes to health and well-being, that's for another day. So within the Caribbean African Health Net, we have, black pastors that we employ, and their role on a day-to-day basis engaging with other church leaders, because we know if we need those low-hanging fruits and reach into our community, then going via voluntary sector organized, but also black majority churches, we can get our, people and to engage with. So we have them working with us. And then, the grants program and capacity building stuff that we've done quite recently as well. So the structural barriers we're trying to tackle is around decision-making, like I mentioned earlier on, as well as representation, making sure that Black voice is in the room and pitching it in a way that is positive and can help, commissioners and service providers really make those reasonable adjustments. Also looking at benchmarking, I have a slide that I will share later on, because resources are tight and we're not naive about that. Usually it's about what will give the best banks for the books. So therefore, how do we work with people to tailor things to respond to, those particular needs? And then racial discrimination, which I talked about earlier on, and poor community engagement. So this slide, if this is shared with you, you can see, but across many health indicators, there are disparities. So right from cardiovascular, fibroid, you have mental health there. So COVID, wasn't as bad as the poor maternity outcomes, respiratory, lung stuff. You can go on and on and on. But, whilst we're one in 4 times more likely to get dementia, it's less likely to be formally diagnosed. Until recently, and great to have the work being done by, Dementia United and, some of the Greater Manchester-wide work. We're told there was only just one person in our community living with dementia, which we knew wasn't brilliant. So we're looking forward to the census data. I know that demographics across Greater Manchester would have changed. We're looking forward to what it's going to show us. But yes, you can see 121% more likely to suffer neonatal death. It goes on and on and on, 4 times more likely to die from COVID and CVD, other CVD-related stuff. But kidney failure is there, twice more likely to have stroke, and it goes on and on and on. HIV, high rates as well. We just after the, Wygate coming, so it's there. And so for us, COVID hasn't really taught us anything new. But, there are many factors, and I'm sure throughout the day, various people have shared stuff. But people's level of education impacts on their outcomes. Being able to speak in a way where you're challenging your clinicians for, second opinion makes an awful lot of difference. We have lots of case studies. Language, if English is not your first language, how are you being supported when it comes to that? But also culture, what people do culturally. And for some people, because there's no talk about, herbal related stuff, then they don't want to engage. So when we got involved with the vaccines rollout, one of the things we had to do when people were asking, so why wouldn't they tell us about prevention? We thought, and because we have clinicians who are working with us, we thought, okay, let's, speak to Manchester Health and Care Commission and get them to fund some vitamin D campaign. So we actually procured, I think it was about 5,000 packets of vitamin D, 120 in the pack. So when government did the press release about clinically extremely vulnerable people and having vitamin D, we put out a further, a response to that, saying it shouldn't just be those who are clinically vulnerable. But what we know, and the data has been there for a long time, if Black people, go and have their vitamin D levels tested, they need a loading dose. And what we were seeing during the pandemic, if people were ill in ICU, they were having 40,000 international units of vitamin D. So when we even had to run the campaign, and this is about benchmarking, the Public Health England guidance about vitamin D was 400 international units. We said to the Health and Care, our CCG, that no, we will go for 2,000. So we had to work with them and get that through the drugs policy team, to do that, because we knew that 400, IU wouldn't really make any difference for us. So some of those things are really, really important. But then for us as an organization, it's about how we continue to engage with our community in a respectful manner, knowing that there are historic issues that won't be resolved overnight. So yes, we've come up with a model which, you can, have a look later on. But for us, consultation shouldn't just be about gathering information and going back. So quite recently, we've been chipping away, whether we work in University of Manchester or University of Bolton or, University of Aberdeen, to say, yes, as part of your dissemination and celebration, yes, you're an academic institution, but you need to have a version that really speaks to those who contribute. And thankfully, that is being heard. I mean, that's another slide we show, but when we talk of benchmarking, it's a classic example. Eat Well Guide. It wouldn't have, our foods on there. So how do you expect people to, be healthy? Meanwhile, we know there are high levels of salt and sugar and other things in our food, and the labeling is another issue altogether. So and we're working with colleagues now, OHID, to look at what can be done. So for us, when it comes to engaging and working and wanting to take an approach to eradicating, just like we've seen around homelessness and the political weight that Andy Burnham is put behind that, and that is meant that people, many more people who are homeless can access healthcare and, other services. It's about making sure we being conscious of those differences. So we even say the black communities are homogeneous. If you're looking at black Africans, you can have Portuguese speaking, French Francophone speaking, and then others as well. So how do we make sure? And when we talk about this, and we're talking about those cultural differences, the solution is not having interpreters. It's about looking at your workforce, looking at leadership, because you need to have those cultural assets in there that can help on a day-to-day basis. And on the 7th of September, there is a piece of work we've done with the Greater Manchester Health and Social Care, local maternity system, which we're going to showcase about collaboration. And it all started because we challenged about, the embrace data and why Black and Asian women are more likely to die during childbirth. What that led to, instead of just looking at, okay, solution, let's jump on and fix it, we said, no, let's work with groups from a bottoms-up approach. It led to, commissioning about 6 Black and Asian-led organizations running focus groups. Then the findings were themed. Where we've ended up with is 13 standards for all maternity providers across, the city region, which is brilliant because it means that it's something that will have longevity. So we're even saying things like, when it comes to equality impact assessment, it shouldn't be someone sitting in the office doing it. It has to be with the community groups that they work with. So they should be more, sort of connectors. And, around maternity, I will chip in this story because stories always help. I'm watching the clock, so not to worry. But, and this, coincidentally, this is a person who is part of my church. He's a taxi driver, is African. He picks up one day a black woman, an Ethiopian Muslim, and they start talking. She was pregnant. And then they had a good rapport. So subsequently, whenever she needed a taxi, she would ask, for the company to get him to do the pickup. And lo and behold, her delivery time, came. When her waters broke, it was a taxi driver she rang after midnight. And he had to drive over to her house, got there because he knew she was Muslim, and those who are religiously aware, you don't shake hands and stuff like that. Baby was coming out. And he was on the phone, 999, obviously rang. And then those in the call center were saying, we need to speak to the woman herself. And he said, she can't really speak English, so tell me what to do. Well, eventually, he delivered the child. But there's a classic example where language is not just having interpreters, but really understanding people's needs and then making sure that, but if you come on the 7th of, September to the cathedral for the showcasing collaboration stuff, then, you hear a bit more. But then, for us, we make references to those historic accounts. So, a lot of the work we did around the vaccine and what gave us the traction, we had one of our clinicians, he would play a clip of Bill Clinton apologizing to black people in the US for Tuskegee trial and where black men were infected with syphilis. And for some people, when they heard that, they knew those clinicians understood where they were coming from. I will never forget October 2020, we organized a webinar for around the clinical trials for COVID because Greater Manchester was leading on a trial as well. In order to get people to it, we had a black GP who is also, a doctor and had been building relationship with the community. He was African. We had a Caribbean bishop who was ill with COVID on ICU, 50-50 chance. And then the lead clinician for the trial obviously was, a white person. When it was his turn to speak, he never showed any slides. When he said, "Can I share my screen?" he brought a photo of his wife, who is Jamaican, his children who are mixed race, and his grandchildren. And that was when people started asking, how do I get involved in the trial? That is what we have to deal with when we talk of some of those historic issues. And then supporting people to engage, making sure we're catering for their language. Also reimbursing people's times, because what we have is lots of service user groups, up and down the country. But usually people are expected to share their experience for free. And usually we say no. So whatever focus group we have to run, as a token, bearing in mind that when we've done stuff around mental health, we make sure there are counselors there to provide support, because we're asking people to relive some of those traumatic incidents. And I think that's really important. Being very transparent when we engage with communities about what is going to happen with the data, when are we going to come back to them, and managing those expectations are really, really important. So that's a bit about the BHIP. You can have a read about that later, but we're not just delivering that in Greater Manchester. We're working in London Borough of Enfield as well. So it's a cultural competency. It's got a helpline to it where we're working with clinicians to really get good outcomes. I mean, one of the early cases that we picked up on was this Ugandan lady, victim of sex trafficking for 5 years, contracted HIV, did not want to have a medication because she said God was going to punish, her perpetrators and those who had subjected her to that. So we had to get a clinician who was also, a minister to really work with the practice and help her. But I do lots of stuff, like I mentioned earlier on, around, faith and health and well-being. And the faith angle is always critical. So whether supporting, NHS blood and transplant specialist nurses who, have someone who is brain dead and the family doesn't want to, consider organ donation because they're praying and hoping this person will come back to life. So sort of wrapping up, lots of work done around COVID. For us, really, what we're hoping for is the lessons from the pandemic will be embedded in day-to-day, healthcare provision. And then sort of wrapping up, it's more about making sure that, whatever, services we're delivering, then we're looking at, and the phraseology is personalization and person-centered approach. But that is how we can get the best from, our patients and clients and those we work with. A couple of reports, but, one on sickle cell. We did our own primary survey during the pandemic to really understand the impact on Caribbean African people across Greater Manchester. It's on there. And then there's a vaccines report every Saturday morning. Like I mentioned, we have our health hour where we have black clinicians on the 16th of January. It ended up being a big event because we asked black doctors who had had the vaccine to come forward and tell the community why they've had that. Ended up with 18 of them and 1,000 on Zoom, 800 people across YouTube and Facebook, all wanting to learn about that. And we did the report. So I will leave it there, but health inequalities is rife, know how to reach communities, and you can make a real difference if we focus on the person as a whole. Thank you.